Well, hello. Welcome, everyone. My name is Dan Tishner, and I'm co-director of the Wayne Moore Center for Law and Politics, and we are delighted you're here, whether you're joining us in person or by live stream. This is a special event for the center because it's part of our Margaret Hallock program for women's rights. This program is named in honor of our founding director, the beloved Margaret Hallock. Margaret, yes. Margaret is a community and institution builder and a formidable champion of women's rights and social justice, and we're delighted that you're here with us. It's a real privilege to introduce to you our featured speaker tonight, Rebecca Grant. Grant is a freelance journalist and award-winning author based in Portland, Oregon. Her investigative work on health, justice, and reproductive rights have appeared in the New York Magazine, The Atlantic, Vice, The Nation, The Washington Post, The Mother Jones. I'm going to keep going. The New Republic, Glamour, Cosmopolitan, Huffington Post, Newsweek. You get the idea. It's a long list. I only covered half of them. Her first book, titled Birth, 3 Mothers, 9 Months, and Pregnancy in America, was published in 2023 by Avid Reader Press and is a winner of the Porchlight Book Award. And she also is a fellow with the International Women's Media Foundation, the International Reporting Project, and the Investigative Fund. And tonight, she is going to be talking with us about her second book, which is right here, titled Access, Inside the Abortion Underground and the 60-Year Battle for Reproductive Freedom. So please join me in welcoming Rebecca Grant to the University of Oregon.
Hi, everyone. Thank you for having me. I'm very excited to be here. Just a quick trip from Portland. And tonight, I'm going to talk about the idea of underground abortion as a feminist practice. So I'm sure, like many of you, my associations with the idea of what an underground abortion was or what it meant, they were not always good ones. I thought of coat hangers and of back alleys, and of an option that was really a last resort that put women in danger. And even though there were so many risks involved in seeking an illegal abortion in the years before Roe, women did it because to them they felt like it was better than the alternative of being forced to remain pregnant. And so certainly there is plenty of truth to those associations, or at least there used to be. But as I was reporting and researching this book, I discovered that there's a really long, robust lineage and legacy of underground abortion networks that were formed by women, by feminists, that spanned generations and borders, and which fundamentally reshaped my ideas about what underground abortion is, but also the role that it plays in society. These discoveries really started with a simple question. In 2021, in the lead up to the Supreme Court's decision in Dobbs versus Jackson Women's Health Organization, I wondered what an underground would look like if Roe versus Wade was overturned. As a journalist who had been covering abortion since 2015, I knew that there would be an underground. I knew that we could expect to see people accessing abortion outside of official channels once those official channels were closed. And because of all the international reporting that I had done over the years, I knew that it was going to have abortion pills at its center. I reached out to sources that I've been working with for years to ask if they knew anybody who was planning to distribute pills through those unofficial channels. And frankly, I didn't expect that anybody was going to agree to talk with me, because why, if you were doing criminal activity, would you talk to a journalist about it? But people, it seemed, were willing. In April of 2022, which was a couple months before Dobbs, I was at a wedding for my sister-in-law on this beautiful property outside of Austin, Texas. It was one of those DIY weddings, so we were all doing everything, and I got a message from a source on Signal, an encrypted messaging app, saying that she had some time to talk that afternoon. I was sweaty, I was covered in flower petals, I was covered in cheese crumbs from the flower arrangements and the charcuterie board. I spent the day making, but I immediately rushed into the house because I knew that I had to take the call. The only unoccupied room in the house at the time was the bridal suite, and it was empty, so I went in, I set up, I was crouched on the floor to type. At one point, the hairdresser walked in, and I kind of went like this to make her go away. But I just knew that this was a really important call, and it was unquestionably worth it, That conversation gave me insight into what the new abortion underground would look like, who would be involved, how it was shaping up, and it gave me a toehold for continuing to report on it as it grew and as it evolved over time. And as I sought to understand more about the philosophy, about the logistics of how they were doing this and how they were approaching the work, I realized that they were building on this strong, if perhaps forgotten, feminist history that extended back decades. And they were being informed by all of these activists who had never operated in contexts where abortion was legal. And so they actually knew what to do in situations like this. So I realized that to understand the present, I had to understand the past. And that led me down this actually really fun journey of all of this feminist history, some of which I had known a little bit about, but a lot of which was new to me. So I kind of started by thinking about or researching, what did the abortion options look like before Roe? People have always had abortions. People will always continue to do so. So it's not as if bans make them go away. So what were they doing? I learned that the only way to have a legal abortion back then was what's known as a therapeutic abortion, which basically meant that if you qualified for one of the limited exceptions, which tended to be varied from state to state, but it tended to be rape, or if your life was at risk, if the maternal health and life was at risk, or if there was a fetal anomaly. But to qualify, you had to go before these hospital committees of men primarily and plead your case, which was a completely humiliating exercise. And of course, not everyone was given the same benefit of the doubt when they were expressing their need. And so for everyone else, the only option really was an illegal abortion, and they had to figure out how to do so. And illegal abortions that were unsafe were so ubiquitous that hospitals had dedicated wards called infected OB. And the complications were, sort of like a cost of doing business for the patients who sought that. They knew the risks, but they still continued to do it anyway. And so, even though there were doctors and nurses and midwives who provided, skillful and safe abortion, they could be harder to find, they could be more expensive. And so often people didn't really know what it was that they were gonna find. They had to rely on word of mouth. And for people who didn't know where to find a provider or they couldn't afford it, there was a whole list of gruesome things that they would use to try, and that's kind of where these associations of the coat hanger and the back alley come from. And in the book, I won't read it all for you here, but in the book, I have a list of I think maybe 25 different implements that had been cataloged at the time. And so it really just goes to show that people, when they were desperate, would try anything. So one of the first feminist activists to speak out against the injustice of abortion bans in this really public and unapologetic way was a California woman named Patricia McGinnis. In 1966, there were 9 California physicians who were charged with providing illegal abortions because they had been providing care to women who had contracted rubella or the German measles, which was a disease that was known to cause fetal anomalies. And there had been an outbreak in the US since 1963, so it was fairly common, and the doctors at UCSF were fairly routinely providing women who had contracted rubella with abortion care. And so as a result, their prosecution led to this nationwide outcry. And there was a lot of doctors and deans of medical schools who spoke up in their favor. So abortion in that way became a national conversation. And Patricia McGinnis, she sensed an opportunity. A few years before, she had founded an organization called the Society for Humane Abortion. And it was the first organization in the country to openly advocate for abortion on demand without apology. In the lead up to the doctor's case, she created a leaflet that said, "Are you pregnant?" in all capitals. "Is yours a wanted pregnancy? If not, why not see an abortion specialist?" And she handed them out all over San Francisco. Inside was the contact information for 2 abortion providers in Mexico, 1 in Japan, 1 in Sweden, and 2 methods for self-inducing abortion, one of which she had tried herself. It was the first draft of what would become known as the list. Word spread about the leaflet, and before long, the Society for Humane Abortion was hearing from women across the country asking for a copy. Over time, it expanded into this robust, annotated, vetted catalog of dozens of providers, which they continuously updated based on feedback from patients and surprise visits to the facilities. They also included tips for safety and discretion, like if you were traveling to Mexico for an abortion, bring a sun hat and a Spanish-English dictionary so that if anyone asked you why you were there, you could just say it was for fun. They also held workshops in the San Francisco area that taught women how to self-manage their abortions as safely as possible, And they published a 169-page book called The Abortion Handbook that they distributed nationwide. During the years that they were active, the list helped an estimated 11,000 women access safe abortions. And in addition to connecting people with providers, their model of a referral network let people know that there were safe options out there and provided a measure of visibility and accountability in what was a shadowy space. In Chicago, another group of feminist abortion activists had a different approach to the same problem. The founder of the group was a college student named Heather Booth. She was a civil rights activist who had spent time in Mississippi during the Freedom Summer. When she returned to Chicago, she heard from a friend who had a sister who needed an abortion, and they asked Heather if she knew where the sister could go. She didn't, but she asked around, and through her contacts in the civil rights community, in the civil rights network, she was referred to a doctor, Dr. T.R.M. Howard, who was a well-respected activist who had lived in Mississippi but had to flee after he ended up on a Ku Klux Klan death list for protesting and being vocal about the murder of Emmett Till. Out of his new office in Chicago, he quietly provided abortion care, and so Booth sent the friend's sister his way. As had also happened with the creators of the list, more women started reaching out. The Whisper network was strong, and she realized that she needed to get more organized. Heather Booth was an active member of many of the local women's liberation group that were cropping up at the time, and so she let others know what she was doing, that she was making referrals for abortion care. Many wanted to help, and so they started to meet. And this was an early version of what was called the Abortion Counseling Service of Women's Liberation, or the Service for short. Today, they are most commonly known as the Jane Collective, or the Janes. And there's been books and movies and a documentary, and they've kind of had this moment in pop culture over the past couple years for reasons that will become clear. But through word of mouth, the Janes found a handful of doctors in Chicago who they could refer people to, and they served as intermediaries. They had a phone number, which was really just one of the Janes' landlines. Callers could reach out, they could express what their needs were. That information would get passed on to another member of the Janes who was responsible for booking an appointment with the providers. The providers would then say, tell that patient to be at this location, at this day, on this time. This is what she needs to know, this is what she needs to bring, and this is how much it's going to cost. And so even though the Janes weren't physically there, they would still, like the members of the list or the creators of the list, they would still get this feedback. So for the Janes, they had a consistent kind of network of places they could send their patients. And for the providers, it was a steady stream of clients, and illegal abortion was a lucrative business. This model worked for a while until one of the Janes discovered that their main provider was actually not a doctor. This was a shock to them because they had been under the impression that he was a doctor, and the care that he provided and his skill and his bedside manner were excellent. His technique, everything that he did, patients always came away healthy. He was very calming, so they were really impressed by him. And the fact that he wasn't a doctor gave them a radical idea. If he, as a layperson, could learn how to do abortions, why couldn't they? A small inner circle of the Janes began training and learned how to perform a procedure called a dilation and curettage, or a D&C. It's a standard surgical technique for early abortions, and it involves dilating the cervix and then using a tool known as a curette to scrape out the contents. It's not a complicated procedure, but it can cause severe complications for people who don't know what they're doing. But before long, the Janes had become experts, and they were providing all of the abortions for the women who came their way, no men needed. And their work was an open secret around Chicago. Their underground model challenged the idea that only male medical professionals could provide safe abortion care, and they put their own spin on how that care happened. They had bohemian bedspreads, feminist education, and books that people could have while they were waiting. Home-cooked lunch was sometimes part of the experience. It was just completely different from any other type of abortions that people had accessed. By the early 1970s, a handful of states had liberalized their abortion laws, and so sometimes the Janes would send women there, so like to New York, for instance. But what was interesting is that sometimes the people that they sent to have a legal abortion in a clinic with medical professionals was actually not as good an experience as people had with the Janes. It was much more clinical. It was just a completely different type of thing. And so I think one of the really important lessons from the Janes and from their work was that it showed that legal medical care wasn't automatically superior, and that underground care could be both empowering and compassionate. In 1972, the police raided the apartment that the Janes were operating out of, and 7 of them were arrested. They had dozens of women on their schedule who still needed help. Unsure where to turn, they reached out to a provider named Harvey Karman, who had been working with feminists in Southern California for years as the main person that they would refer to. He worked out of a room behind a dental clinic on Santa Monica Boulevard, and he was not a doctor, but one of his claims to fame was that he had helped to invent a new and less invasive abortion technique, one that was simple enough that lay people could use it themselves. So while the primary early abortion technique at the time was the D&C, which the Janes used, doctors were also starting to experiment with using suction to empty the uterus. Karman's innovation was that instead of a rigid plastic cannula or a metal cannula, he had this like soft, flexible cannula that he came up with that was much easier to insert into the uterus, and it reduced the chance of perforation and infection, which were some of the biggest risks of abortion. He taught this method to the group of feminists who referred to him, and like the Janes, they realized that with proper training, they could do it themselves. This group of activists was casually known as the West Coast Sisters, and they referred to this technique as menstrual extraction, not as abortion, and they espoused an ethos of self-help. Their idea was that women could do this with each other, by each other, for each other, among each other. They didn't make referrals to male providers as the list did. They didn't become providers themselves like the Janes did. Instead, they came up with what they saw as a distinctly feminist practice that had to exist outside of the male medical establishment. They didn't see it as a service or as a means to an end, but as a feminist practice. And in fact, when the West Coast Sisters visited Chicago on a cross-country Greyhound tour, they met the Janes, and they all exchanged some of their ideas. The Janes were actually appalled when they heard what the West Coast Sisters were up to. They thought that this new method was untested and too risky. You know, they had gone through all of this training to learn how to do this, so the idea that people were just kind of like, you can do it and you can do it was a little stressful to them. Also, D&Cs were faster, and because the Janes operated at a really high volume, it just wasn't a good fit for their service. But they did learn something from the experience, and they started offering many of their clients speculums if they wanted to check out their own reproductive areas on their own when they were at home. For their part, the West Coast Sisters were not that thrilled with what the Janes were doing either. They saw them as recreating this hierarchical provider-patient relationship rather than upending the hierarchy altogether. When the Supreme Court issued Roe v. Wade in 1973, these differences became less relevant. The underground networks had been a response to the problem of unsafe abortion, and with legal abortion, they no longer saw their work as needed. The underground largely disappeared, although many of the people who had been active ended up working in the legal abortion space, whether they were part of clinics or they ended up working for abortion funds. But even though the underground as it existed was gone, the feminist idea about how to provide abortion care informed the legal clinic-based system that sprang up in the wake of the decision. And as would be true decades later, the fact that these groups were facilitating abortions at a massive scale undermined the idea that abortion bans stopped abortions, because they didn't and because they don't. Roe was a huge victory and a major milestone, but from the very beginning, abortion access was embattled as states passed law after law to restrict it. Making it legal opened it up to legal attacks. And for the American reproductive rights movement, the fight became primarily focused on politics and on the courts. That countercultural, anti-establishment attitude that had motivated people, before Roe, that faded away. Elsewhere in the world, though, that spirit was brewing, thanks to a new pharmaceutical technology. In 1988, a drug called mifepristone was approved in France for use as an abortion pill. It worked by blocking the hormones necessary for a pregnancy to continue and had to be taken together with a drug that caused contractions to expel the contents of the uterus. It took 12 years for mifepristone to get approved by the FDA and for medication abortion to become available in the US. It was a long and a hard battle, and one of the main concerns seemed to be that abortion with pills would make it too easy. a concern that had also been raised about the suction technique. When it was approved, the FDA classified mifepristone as a highly risky drug, even though the evidence indicated otherwise, and they heavily restricted it. It could only be prescribed in brick-and-mortar clinics, which meant it wasn't any easier for patients to access than a surgical procedure. The radical potential of the little white bombshell, as the New York Times had described it, remained dormant. But that wasn't the case outside of the US, where people were creatively using the pills to develop new pathways for access. In the late 1980s in Brazil, physicians started to notice a dramatic drop in patients suffering from complications of unsafe abortion. Brazil had a strict abortion ban and all the high rates of maternal mortality and morbidity that come along with it. When all of a sudden those rates went down, a team of public health researchers were wondering what was going on, and they set out to learn why. They discovered that word was spreading rapidly about a drug called Cytotec. The name of the drug itself was misoprostol, and the brand name was Cytotec, and it was an ulcer drug, but it had a warning on the box that said, "Do not take while pregnant," because it could lead to miscarriage. Somehow, women and pharmacists had figured out how many pills to take at what interval in order to safely and effectively induce an abortion outside of a medical setting, known as a self-managed abortion. The combined regimen of mifepristone and misoprostol together is considered to be the gold standard, but misoprostol can be taken on its own to end a pregnancy. And while mifepristone was not widely available, misoprostol was. And word of it spread so fast into so many people that there was a noticeable, I'm gonna mess this word up, but epidemiological shift in how many people were visiting hospitals with complications from unsafe abortions. This was revolutionary. It meant that legality was no longer synonymous with safety, and safety was no longer had to be synonymous with legality. It could change everything. And just as activist groups in the year before Roe had used the resources and technology at their disposal to come up with a range of models for access to abortion outside of legal bounds, so were activists decades after them doing the same thing in different ways with pills. One of the activists who recognized this game-changing potential was a Dutch doctor named Rebecca Gompertz. In the 1990s, she had served a stint as a doctor aboard a Greenpeace ship that conducted dramatic campaigns to protest environmental degradation. The ships aimed to both mitigate environmental harms and raise public awareness about them, and Dr. Gompertz had a bold idea. What if you could apply the same principle to abortion? According to maritime law, which she learned from her boyfriend, the sea captain, boats are subject to the laws of the country that they are flagged to while they are in international waters, which is usually 12 nautical miles offshore. Gompertz wondered then whether a boat that was flagged to the Netherlands could provide abortions to women in countries with abortion bans if they sailed to international waters. It took her years to do the legal research, raise the money, outfit a gynecological clinic in a shipping container, rent a boat, and assemble a crew. But in 2001, her organization, Women on Waves, set sail for Ireland with 20 doses of abortion pills on board. The voyage, predictably, was a media frenzy, generating phrases like reproductive battleship and abortion pirate. In the end, due to conflict over licenses, the crew did not provide abortions on that trip. But 3 years later, they tried again on a journey to Poland, which had some of the strictest abortion bans in Europe, and they were successful. They ended up providing abortion care to over a dozen women 12 nautical miles out at sea. The next year, Women on Waves sailed to Portugal, where the Minister of Defense dispatched a naval warship to stop them. They didn't end up being able to enter the territorial waters, but the image of this tiny little boat with a handful of feminists on board and these two huge hulking warships was just, an image that went around the world. And it really conveyed this idea that abortion was so threatening that a country marshaled its navy to try and stop it from happening. Undeterred, Dr. Gompertz ended up going on a Portuguese talk show, and on air, she held up a box of misoprostol that one of her crew members had purchased in a pharmacy, and she explained how to use the pills, how to buy them, how they worked, what to expect. She did all of this on television, publicly on air. She told women that they were safe and effective, and they were available wherever they, went to get their medicines. And it was the first time that this information had been shared in such a public way. Up until then, in places like Brazil, it had really been that whisper network, that word of mouth. But this was live on air, and the information spread like wildfire. With the pills, the idea of what an underground or a self-managed abortion looked like was taking on a new form. With the right information, it could look like buying medication in a pharmacy and taking it at home. And so, as was her inclination, Dr. Gompertz continued to innovate. In 2008, Women on Waves planned a campaign in Ecuador, but their boat was destroyed in a storm. So instead, the activists painted an enormous banner that they hung from a statue of the Virgin Mary on a hill outside of Quito. The sign had a phone number for a safe abortion hotline. When women called, volunteers answered the phone and gave them instructions for how to buy misoprostol in a pharmacy, how to take it correctly, and answered whatever other questions that they had. The Safe Abortion Hotline became a staple of international abortion pill activism. Gompertz also wondered whether it was possible to prescribe abortion pills over the internet. As she had done with the SHIP campaigns, she looked into legal loopholes, and she discovered that while there was no one single country in the world where she could launch a telemedicine abortion service, if she divided it up so different functions happened in different places so that every single function was legal in the place that it happened, it might actually be possible to create a telemedicine platform that was fully legal. She hosted the website in Canada, got her Austrian medical license to prescribe the medication, had the prescriptions filled from a pharmacy in India, and took payment from a foundation in the Netherlands. With that, Women on Web was born. It was the world's first global telemedicine service and has since mailed abortion pills to over 130,000 people and counseled 500,000 others with information. In many ways, Gompertz's mission was to blur the boundaries of underground abortion. She was creative and radical and bold, but she was also a physician prescribing medication. Everything she did was public, and all of the research that she had done and consultations with lawyers were geared towards setting up models that were, if not legal, were not illegal either. She wasn't trying to upend or tear down or undermine the entire medical legal system. She was exploiting ambiguity, finding loopholes, and maneuvering in gray areas to highlight that everyone deserved access to care. The fact that the medications were legally prescribed was the point. Activists elsewhere also had ideas about how to leverage abortion pills. And similar to the philosophy of feminist self-help espoused by the West Coast sisters, they actually thought it was important to remove physicians and to remove government approval from the equation. Instead of working within the system, they wanted to create a new system entirely, one based on sisterhood and on solidarity. In the year 2000, the same year that the American FDA approved mifepristone and Rebecca Gompertz founded Women on Waves, a community organizer in the Mexican state of Guanajuato, Mexico, named Veronica Cruz, was organizing to stop a new abortion law. The only exception to Guanajuato's abortion ban was in the cases of rape, and the state legislature was debating whether to remove it. Vero and a group of feminist compatriots began meeting in various spots around the city to talk about what they wanted to do to stop it. They called their group Las Libres, which means the free ones, and they were instrumental in mobilizing large protests against the measure, and they were successful. It was a victory, but Vero realized that the right to abortion was meaningless if people didn't know where to go to access it, or if there was no place where they could go to access it. The right had to be coupled with access. So she asked around, and she found a female OBGYN who was willing to provide abortion care to rape survivors and started sending women her way. She also accompanied them during their appointments to provide emotional support, and she saw how meaningful that was. When the OBGYN returned from a trip to an international conference of OBGYNs, she had learned about medication abortion, and she told Vero that she thought for the patients who that was a better fit, that that's what she was going to start to do. She would prescribe the medication instead of providing the surgical technique. And like many feminists who came before her, Vero was there, she observed, and she thought, I could do this too. That's how the model of underground abortion care known as accompaniment got started. When women reached out to Las Libres, they were assigned an acompañante who told them how to buy and take the pills and what to expect. Women who could afford to buy misoprostol in a pharmacy were asked to hold on to their extra pills. The boxes came with 28, but most women only needed 12 to 16 to self-manage their abortion. And so they then passed on the extras to the women who couldn't afford it, in addition to providing emotional support. All of the members of these networks were people who had had abortions themselves and who went on to help others, serving as links in a chain. It was a non-hierarchical peer-to-peer model with no judgment and no stigma, and those networks proliferated across Mexico and beyond. Ultimately, they would make their way to the US. By 2010, accompaniment networks and safe abortion hotlines had spread across Latin America. From Mexico all the way down to Argentina, feminist activists had put their own regional spin on these models. There were differences in the exact structure of how they shared information, distributed the pills, and offered support, but on a truly massive scale, they were providing safe and effective abortion care in countries with strict abortion bans, and governments were largely powerless to stop them. Academics have described this type of work as transformative illegality, and it functions on multiple levels. One, of course, is to provide safe abortion care in illegal contexts, and to save lives by doing so. But the other is that by subverting abortion bans, underground networks undermine the laws themselves, and the idea that governments can control what happens to the bodies of its citizens. It's a demonstration that the government is not in charge, that their authority does not extend to individuals' bodies. And this is a powerful social, political, and cultural message, and it has had an undeniable impact. In 2018, the Republic of Ireland voted to repeal its constitutional ban on abortion. During a parliamentary debate over the issue, Women on Web was cited as an example of how the country's ban was doing little to prevent people from having abortions in the era of the internet and of pills. Given the safety, efficacy, and ubiquity of self-managed abortion, maintaining the law seemed like a pointless and outdated exercise. And in Argentina, years of protest, public pressure, and activism had led to the legalization of abortion in 2020. Argentina is home to the Socorristas en Red, which translates to Network of Rescuers. The Socorristas encompassed over 50 smaller abortion collectives across the country and 500 activists. It's one of the most visible, organized, and vocal networks for self-managed abortion in the world. Between 2014 and 2020, they helped nearly 41,000 people have medication abortions, and they worked closely with feminist physicians and published data in partnership with researchers on their website about their outcomes. They also developed some of their own programs or protocols for medication abortion later in pregnancy, and in that way advanced knowledge about abortion care and about medication abortion even beyond what doctors and scientists had done on their own. Technically, they were facilitating underground abortion, but they were doing it in a way that was about as of-ground as could be. Again, this version of underground abortion wasn't some clandestine, shady, dangerous thing. These activists built a version of the world that they knew women deserved, where abortion was not stigmatized and was freely accessible to whoever needed it. They didn't ask for permission or wait for political reform because people needed help in the moment. Instead, they paved the way and forced the established institutional powers in their countries to catch up. In their capacity as underground abortion activists, they became agents of historical change. During the 2010s, there was positive momentum around abortion rights all over the world. But in the US, the picture was more complicated. After the 2010 midterm elections, Republicans made huge pickups in political power across all levels of government, and many states began passing what are known as trap laws, targeted restriction of abortion providers. These laws professed to be about health and safety, but in reality, they were thinly veiled attempts to shut clinics down, and they were effective at doing that. A trap law that went into effect in Texas in 2013 caused half of the state's clinics to close. Clinics shutting down, of course, made abortion harder to access. Patients were having to travel farther distances and experiencing longer wait times, with all the logistical and cost barriers that entailed. For anyone who couldn't afford hundreds of dollars for a procedure, who didn't have access to a mode of transportation, who couldn't have time off work, who didn't have childcare, who was a minor, who was in an abusive relationship, or any of so many reasons why people might struggle to get to a clinic on a designated day at a designated time, abortion was a right in theory only, not in practice. In 2016, the Supreme Court ruled that trap laws were unconstitutional if they imposed an undue burden on abortion access. It was a win, and the future of abortion access in America seemed safe until a few months later when Trump won the election. We all know how that went. During his first term, he stacked the Supreme Court bench with justices who, regardless of what they said during confirmation hearings, seemed willing to overturn Roe v. Wade. And yet, despite the escalating threats to abortion access, mifepristone remained under regulatory lock and key. It was regulated as if it was this highly dangerous drug with an in-person dispensing requirement that prevented it from being prescribed remotely and sent in the mail. Patients had to go to a clinic to get it. And then came the outbreak of COVID. Suddenly, the supposed risks of telemedicine abortion which, to be clear, were not based on evidence, seemed less risky than the alternative, which is to have pregnant people travel long distances and sit in medical clinic waiting rooms during a global pandemic. Any arguments against remote prescription seemed ridiculous, and the FDA lifted the in-person dispensing requirement. This was a big step forward, but as always, every gain was soon to be overshadowed by losses. On June 24th, 2022, the Supreme Court issued its decision in Dobbs versus Jackson Women's Health Organization, which overturned Roe versus Wade. Within 2 months, 21 million women of reproductive age had lost access to abortion in their state. When the Dobbs decision came out, Dr. Rebecca Gompertz was ready to swoop in to help. She had never extended her services to the US before, but by 2018, she was hearing from enough American patients in dire circumstances that she decided to launch a telemedicine platform called Aid Access. The way that Aid Access was structured evolved over the years, depending on the legal landscape. At first, she used the same international telehealth model as Women on Web, which is that she wrote the prescriptions under her Austrian medical license, and the prescriptions were then filled from a pharmacy in India. The downside of this approach was that the prescriptions could take 3 weeks, if not more, to arrive, and that wasn't always something that patients could wait for. With the regulatory change during COVID, that was the moment that she had been looking for. And she started recruiting American providers, and she fully pivoted to American-only provision in 2023, after blue states started passing shield laws. These were laws that protected doctors and nurses who sent medication abortion to states with bans. So if there was a physician in New York who prescribed medication abortion to a patient in Texas, New York was pledging to protect that provider in New York. As always, Gompertz was blurring the boundaries between legal and illegal, between self-managed abortion and abortion care with physician oversight. The providers in her network were practicing above board, but the people they were serving had to take the medication in secret and maintain the utmost discretion. And because Aid Access was made up of licensed medical professionals, they were subject to legal and political forces. There were multiple efforts in the works to rescind the FDA's approval of mifepristone after the Dobbs decision, or to revive the 19th century Comstock law, which banned the mailing of obscene materials. In those cases, Aid Access would have to pivot. Also, Aid Access charged patients on a sliding scale. Their fee was far less than medication abortion in a physical clinic, but it was still out of reach for some patients, which is why a cohort of activists decided that it was time to revive the American underground in the era of abortion pills, an underground that did not involve doctors and that would mail the pills outside of regulatory channels for free. One of those activists was Stephanie, who was the woman that I spoke to in the bridal suite at the wedding. She had gotten involved in organizing and fundraising and volunteering for reproductive rights after the 2016 election. When COVID hit and all the clinics in her area shut down overnight with no clue when they'd reopen, she quietly started to mail people envelopes of misoprostol that she bought from a doula friend of hers, since misoprostol is routinely used during childbirth. In the lead up to Dobbs, she wanted to scale up her operation to prepare for the overturn of Roe, and so she started searching for a source for mifepristone. She bought some kits from Dr. Gompertz, but that approach was expensive and not scalable, as Dr. Gompertz was not really set up to sell people bulk quantities of pills. And then she heard that Vero Cruz of Las Libres had made a really appealing offer. For anyone who wanted to travel to Mexico, they could have medication abortion for free, as long as they were willing to bring it back in their luggage. One of Stephanie's co-conspirators, a woman in her 80s who I called Jenny, had a trip to Mexico planned, and she offered to meet with Vero. Going in, she wasn't sure if she was going to take the pills, if she felt comfortable smuggling them back, but she decided to take the meeting. And so they met up at a Starbucks in the tourist town of San Miguel de Allende. It was broad daylight, it was the middle of the day, and they sat down and they were sitting, and Vero was just talking about the pastillas and the pills, and this is how you want to smuggle them, and giving her all of these tips completely loudly and out in the open. And her boldness really inspired Jenny. Jenny had worn her sunglasses, looking like a woman on the run in a spy thriller. She had her large black backpack. I mean, she really was there to do some kind of covert, clandestine work. And then there was Vero just being like, here you go, and handed her 50 mifepristone pills. Jenny then went around town to different pharmacies and she bought misoprostol, which nobody batted an eye about selling to an older American who had gone to Mexico to buy cheap drugs. She then took all of the mifepristone out of the packaging that it came in, and she put it into one pill bottle. She popped all of the misoprostol pills out of their packaging and put that in another pill bottle. She put the Miffy in her carry-on suitcase and the miso in her checked luggage, and then she made her flight home. She had become a pill smuggler. She was nervous, but nobody even batted an eye. She sailed on through customs, and when she was asked if she brought any souvenirs home, she said no. No one gave her a second look. This type of smuggling was playing out all across the border. In addition to Jenny, there was a large cohort of expats who lived in San Miguel de Allende and who had asked Vero to come speak to them about what they could do. After Dobbs, they were angry, they wanted to do something, they wanted a channel for their anger, and then just one town over, one city over, there was, a globally renowned abortion rights activist who seemed like she knew what to do in a situation like this, and so they hosted her for a little potluck, and she basically said, anyone who's willing to smuggle the pills, I'll give them to you, you just have to get them across the border. And so this network of expats started recruiting their family and friends, and anytime they went back to the US, which was all the time, by plane, by car, they would bring some pills with them. And then in the US, they would send them on. In the beginning, when their the volume was lower, they would mail them to individuals who had reached out to request help. But as the volume picked up, they ended up shipping them to kind of these central distributors who were part of the network. As the demand soared, it became more than Las Libres could handle. For one thing, they didn't have any native English speakers on their staff. They spoke Spanish, so they did the best that they could. They created a poster in the office that had common English phrases. They used Google Translate, but really for people who were asking questions about abortion, they felt like it was important that there were English speakers responding to them. And so a group of American expats who lived in Mexico, who knew Las Libres and had worked with them before, they offered to step up and form their own American wing of the organization. They decided that they were going to do this their own way, so they were kind of autonomous and independent, even though they were using the same model as Vero. But as one of my sources described it, they were very gringo about it, and that they wanted there to be more systematization, they wanted there to be more careful security protocols. They wanted there to be a form that people filled out at the beginning to manage the demand. And for most of the people who were involved, this was just a thing that they were doing as volunteers. Many of them had full-time jobs and they had families, but they were going to dedicate countless hours of their time to responding to the inquiries and running this, whole operation. Stephanie, that source who I had talked to during the wedding and who had gotten really active during COVID, she also was getting more organized about how she was going to approach growing what had been her little regional statewide network into a national network that could serve people at scale. There are some differences in how Stephanie's network operated and how Vero's network, Las Libres' network operated, but for the most part, there's pretty much operate in the same way. There's an encrypted email address that people can fill out, abortion seekers can fill out and contact to request pills. When they request the pills, the orders are then passed on to specific distributors who are in the US who are responsible for putting envelopes with individual doses of medication in the mail. The pills can't be shipped from abroad because they're more likely to get flagged by customs. And so that's why the people would smuggle pills over the border. They would get them to these individual distributors, and then they would mail them out envelope by envelope. On the back end, the leaders of the network are responsible for obtaining the medication in bulk quantities and passing it on to this network of distributors. They mostly rely on generic versions of the medication from India, which they can buy cheaply and off the books. These type of networks refer to themselves as community support networks. While some don't love the framing of their work as underground, I use the term because I think it evokes the nature of what they're doing. They're operating outside the law, outside of medical and regulatory oversight, and may take on considerable personal risk to ensure that channels for abortion access remain open. Of course, self-managed abortion is not a good fit for everyone. Medication abortion is not a good fit for everyone. Some people have contraindications that means they can't take the medication, or they prefer a procedure that takes 15 minutes as opposed to the process of the pills, which can take days. Others don't have a safe or stable home environment that they can take the pills in. They might not have access to the internet, or they might not know how to use some of the technologies that are involved, like sending an encrypted message. Or they just might want the oversight and the sense of legitimacy and support of an in-person environment. There will always be a need for abortion clinics. There will always be a need for in-person care, and people deserve to have the full range of options at their disposal so they can pick the one that is right for them. Still, these days, self-managed abortion is far from a last resort. It's safe, it's effective, and there are plenty of people who prefer the convenience, discretion, and affordability that it offers. While the work of the underground activists is filled with daring and spycraft and intrigue, I was also struck by the mundanity of it. Much of the work involved running what one source referred to as a nefarious abortion cartel, involved stuffing envelopes, responding to emails, trawling Zillow for empty homes to use as decoy return addresses, and schlepping to post offices. It is not glamorous work, but it is important. In so many ways, the underground of 2025 looks wildly different from the underground of 1965. There are pills, encrypted email addresses, and signal messages, and internet resources, and covert mailing practices. But beyond the surface, there are striking similarities. There's a clear legacy. Then, as now, a core part of underground abortion networks is sharing information for how to access abortion safely outside of the law. Then, as now, there are activists willing to skirt the law to break down barriers and ensure that channels for access remain open. And then, as now, they are motivated by a deep conviction that abortion is a human right, that gender equality can exist without it, and that all the risks are worth it for the cause. Then, as now, they refuse to accept abortion bans as the status quo. In most cases, they are normal people, some without even a background in political organizing or protest, doing remarkable things and putting themselves on the line to help women be free. Their faith in institutions has crumbled, and they no longer believe, if they ever did, that doctors or lawyers or judges or politicians are coming to save them. They hope that the laws will change, but they are not waiting for that to happen. They are prepared and determined to keep fighting as long as there are people who need them. Thank you.
So we have time for questions. So if you have something you'd like to pose to Rebecca.
Thank you so much for the book and for coming to talk about it. I'm just wondering why you think that the U.S. is so far behind. Is it because we have a really virulent anti-abortion culture and legal system that caused us to be so legalistic and institutionalized? Or did we go to sleep with Roe? Or but, you know, I remember listening, Vera came to Oregon and talked about I forget what it was, but she was very inspirational, but it didn't take hold. And at least then, that was well before Dobbs, so.
Yeah, I think it's a few things. Hopefully I remember them all right now. But I think one certainly was a sense of complacency. After Roe happened, there was this sense of victory. There was a sense that it was settled, that it was the law of the land, that it was inviolable, that it could never be taken away. And so I think because of that, the kind of mainstream reproductive rights movement really became defensive rather than fighting to expand access or really fight for abortion for everyone. I think for the most part, because there were so many anti-abortion attacks that kept people so busy, it was kind of constantly like being on the back foot. And I totally understand why that was. Throughout the 80s and 90s, there was horrific violence against abortion providers. There were political realities. I mean, you know, the US is a huge country, and even if partisanship has gotten worse, it's not as if it was never there. And so the anti-abortion faction is really powerful. So I think that there was a sense of complacency. There was just this constant sense of embattlement. I mean, truly, when I was doing some research about the immediate aftermath of Roe, I mean, the efforts to restrict abortion started immediately. And really what they tended to do was to go after what they felt like were sort of the easy things to go after. So the Hyde Amendment, I think, is such a big one, which basically said that federal Medicaid funds can't go to covering abortion care, which meant that for low-income women, they would have to pay out of pocket. And so and the Henry Hyde, who was the guy who wrote that amendment or really pushed for it, basically said, I would like to ban abortion altogether. This is the low-hanging fruit. This is what I can do. So I'm just going to go after, poor women's access. And so I think when you're constantly having to fight battles like that, it's hard to have the bandwidth and the political capital to really fight for an expansion of access. But at the same time, there were so many cases throughout history, some of which I document in the book, where I think the mainstream reproductive rights movement had an opportunity to fight for a bigger vision, to fight for the rights and the access of poor women, and they chose not to because they were worried about being labeled as too extreme or too radical, or that somehow that would lead to, kind of paring back access. And so I think there was this sort of sense that as long as the right was there, that's really the thing that matters. And I think one of the most, I'm certainly not trying to say that the Dobbs decision was a good thing, believe me, but I do think it has really catalyzed this shift in thinking from a rights-based framework to an access-based one. And that's something that reproductive justice activists have been talking about since the 80s, probably before, so that's hardly a new idea. It's that thing I was talking about where the right doesn't matter if people can't access it, but I think that there was a way in which Dobbs really forced people to see that and to reckon with it in a way that I do think maybe, hopefully, because I'm desperate for a sliver of optimism, could yield in the long term maybe a movement that's more willing to fight for what it really needs, right? I mean, I think abortion for people later in pregnancy is another one of those sort of third rail issues. And when you really dive into it, you see that those types of bans are so harmful to people who are going through really traumatic, I could talk about that for a while, which I won't right now, but I just, it's like we have to fight for everyone. And the movement is weaker when we don't.
Hi, it was nice to hear you talk again. We had Rebecca Grant in our class earlier this morning, which is really fun, or afternoon, sorry. But what do you imagine the reproductive access landscape will look like in a decade or two from now, specifically in the US?
Ooh. I hate to make predictions, but I think that, I think it's building on my point that I was just talking about, which we spoke some in class earlier, which is that one of the most powerful ways, based on my reporting and research, to undermine abortion bans, to undermine really restrictive abortion laws, is to flout them, is to subvert them, is to make it so that the laws don't really have that much of a bearing on people's access to care. And again, not trying to downplay the severity of the Dobbs decision, of course, but a thing that many people, including me, were surprised by is that abortions have gone up since Dobbs, consistently. And that's not even including the numbers of self-managed abortions, which are, for obvious reasons, hard to collect data on, but there's been a lot of them, at least 100,000. And so I think that regardless of what happens legally, I do think that this grassroots activist model, I think, is going to become even more salient, even more powerful. Maybe that's just wishful thinking, but you see that happening in other countries with abortion bans, and I think we'll see it happening here. I also wonder, which we did speak about a little bit in class today too, so much of the political momentum that led to Roe versus Wade back in the 70s was just this inescapable harm of what abortion bans did, of the harms that they caused, of women who are showing up to hospitals with complications, of deaths. And we've already been starting to see that. Pretty soon after Dobbs, there was the first case of sepsis popped up in Oklahoma, and it was within, 2 months or something. And so I think that I don't want this to happen, obviously, because it means that there's a lot of pain and suffering, but I think we know from political polling that abortion is very popular. Over 70% of the country supports at least the right to abortion, the right to choose. And so I think that there is the potential that enough people support abortion access the harms of what Dobbs is doing are clear enough. It's clear that the abortion bans that these politicians are trying to impose aren't actually curbing access to abortion in this way that, because of all those factors, it feels really hard to predict. But I do think there is a day when constitutional federal legal protections will be restored. Do not know what that timeline is, but I like to keep hope alive.
I'm thinking a little bit about the first question that was asked and thinking about what are some political movements that currently exist in this country that could connect with this idea of working outside of established legal and political structures for solving problems generally. Mm-hmm. And I'm thinking, as a Portland resident, I'm sure that you're familiar with a lot of groups who have set up mutual aid programs, and wondering what kinds of similarities or possibilities might exist with this kind of model, and either having networks like that live within mutual aid networks, or what that relationship could look like.
Yeah, I love mutual aid networks. I think they're doing incredible work. Over the years, I've reported on some of them. There's an abortion fund in Texas is a big part of the book, and they have a mutual aid component. And I do think that kind of community-based grassroots care is a way forward. It's not the only way, but it's absolutely critical. And really what a lot of these community support networks that I talked about are, even though they're very focused on distributing abortion pills, a lot of them are doing mutual aid work in other ways, as are abortion funds, and some of them are expanding their remit of what they do. So the fund that I focus on in Texas, they've also started offering like free diapers and kind of stuff like that. And so I think that a lot of that is the influence of reproductive justice, but I think that abortion organizations, kind of regardless of where they are in the ecosystem, are thinking more expansively of what that work looks like. And this wasn't quite your question, but I'll talk about it anyway, which is that one of the really interesting maybe parallels or forerunners to the kind of underground abortion networks as they exist now was the AIDS activist movement in the 1980s. And I sort of found my way there because I was really curious as to why all of the medication that my sources were bringing into the US were generics from India, pretty much. And I was like, well, why is it all from India? What's the deal with India? And India has this huge pharmaceutical industry. They're the largest exporter of generic pharmaceuticals in the world. And I was like, okay, well, why is that true? And this was just one of the fun little tangents I get to go down as a journalist, but a lot of the reason was because India had this kind of nascent pharmaceutical industry that they were trying to make a bigger deal, and then when AIDS activists were fighting for access to affordable pharmaceuticals, many of them started traveling to India, and they were kind of buying and trying to cobble together their own regimens, because since the government was refusing to do research and was denying them access to life-saving medication, they had to go elsewhere to find that medication. And so some of you might be familiar with Buyers Clubs, and there was that movie, I don't know when, but with Matthew McConaughey called Dallas Buyers Club. That's really what those ideas were. They were like these mutual aid societies of people who had AIDS, and they figured out amongst themselves, how do we access the medications? What medications do we need? How do we take them? What are the combinations? They figured all of this stuff out, and they had to teach it amongst themselves and kind of build the network and the ecosystem and the healthcare model that they wanted to see. And they were also operating in this really stigmatized environment, right? I mean, treating AIDS patients was something that, even there were physicians who wouldn't do. So I found that to be a really, actually quite direct and fascinating comparison of what it looks like to provide stigmatized care. And there's even, the similarities extend to traveling to India to get the medication. So I think that, it's like that idea of when there's some kind of stigmatized thing and the government wants to deny it to you, people band together and figure it out.
Hi, thank you so much for being here. I know a little bit about rights, the right to versus access to, and a group of students here at the University of Oregon on trying to win access to medicated abortion on our campus. And I'm wondering if you could speak a little bit to the importance of that care specifically on a college campus, and then broadly speaking, if you have any advice for fighting that fight.
No. I don't know if you've looked into this, but there was a really kind of public case where students in New York, I think at Columbia, were fighting for this. So they would probably have really, really good advice. But no, I mean, I think that's an incredible and important cause, and I'm so glad that you're fighting for it. I don't know what the holdup is or if anyone in the room knows, but let's work on that. But I guess the main thing that I would say is that medication abortion, and mifepristone kind of specifically, has had so many extra regulations piled on top of it from day one. So even though the FDA has removed some of the restrictions around remote prescription and mailing, mifepristone is still part of this program called REMS, which is just reserved for the most dangerous drugs that are, like the other stuff on that list is like, antipsychotic drugs, and it's just things that aren't nearly as safe and effective and don't have the same proven track record. And so I think what those regulations do is they make it much more complicated for the provision to happen outside of kind of the traditional channels, which maybe could be part of the issue, but they also have this stigmatizing effect. And so I think that, I think I would maybe need to know a little bit more about what the specific holdup or barriers is, but I would hope that, awareness of other similar programs, of the safety and efficacy of the medication, and not only of the medication itself, but of taking it in, outside of a clinical environment. There's so much data on that. So of course I know very well that you can't just give all of the accurate, right information and hope for the outcome that you want, but yeah, sorry, that feels like an unsatisfying answer, but it's a good fight and I'm glad that you're fighting it and I hope you're successful. Yeah.
Can you speak a little bit about the role of Planned Parenthood and the kind of traditional medical system that's now doing virtual visits and mailing prescriptions and stuff?
Yeah. Yeah, I mean, Planned Parenthood is an incredible organization that has served so many people and is a critical lifeline for reproductive health care, particularly for low-income folks, and they've been doing this for a long time, and they're embattled right now. I mean, I know locations are having to close even in blue states because of the funding. And I think that clinic-based care, or the traditional type of care with the medical oversight, no longer necessarily needs to be the norm for everyone. And I'm always really careful to emphasize this because I think it can get sort of simplified, which is that I'm certainly not advocating for outside of clinic care or self-managed abortion for everyone. I think we need organizations like Planned Parenthood. We need the brick and mortar clinics. They're really, really important. But there has been over the years, and it's getting better, but there's been a lot of tension within the movement between the more traditional kind of clinic-based institutional providers and the grassroots activists and kind of the upstarts and the people who are going a little bit rogue, and that makes sense. It makes sense that they wouldn't agree, right? I mean, I think every social movement, you're gonna have the people who have this institutional vision, this long-term vision. They have so many employees, they have clinics to run, they have to be slow and cautious and do things by the book, and things aren't gonna move unless there are people who are these sort of rule breakers and creatives and visionaries who are thinking of a way forward and dragging everyone along with them. And I think, in the book, there's a couple visionaries I really focus on. Dr. Gompertz, I think, of course, is one, Vera Cruz is another. And it's not so much that I necessarily believe in this great women or great person version of history where there are these singular historical figures that have these huge impacts. I mean, I think that can be part of it, but I think ultimately it's these people who are seeding this radical vision and then everyone else catches up. And they almost always do catch up, right? Dr. Gompertz was doing telemedicine abortion care. She launched Women on Web in 2005. Telemedicine abortion care became something that was available in the US in 2020, right? So she was 15 years ahead of the curve, and she gathered so much research, she tracked all of the outcomes, and that research was part of what made the case for the legality later, but it's a 15-year delay. And so I think that ultimately a robust and healthy ecosystem has all of these different factions, has all of these different approaches, and they're working together. That is not really the reality of what happens a lot of the time. Of course, people are gonna fight, they're gonna argue about tactics and and strategy, they're not going to disagree, but I think that they're both kind of signs of this healthy ecosystem. And so I think it's great that, Planned Parenthood has started doing telemedicine because, patients really like it. It's great that they, in some cases, I'm not sure if it's national or just on an affiliate level, but some of them have information about self-managed abortion on their website and share research and resources. That took a really long time, and there were a lot of people who kind of fought with them and worked closely with the organization to get there, but they did get there, right? And so, I just think that there's not a right way or one way, and I think that kind of thinking ultimately creates division within the movement when it's stronger when people can work together, but it's hard. And I know that people in both camps, because I've interviewed them and I've heard them snipe about each other, they can get really frustrated, and maybe that's healthy, but I think that tension is part of it.
I'm going to sneak in a question. I wonder if you could talk about access in the global South. As you were talking about kind of optimism versus pessimism, and as I was reading the book, it was amazing how much vibrancy there is there.
Yeah, I really tried to drive this home in the book, which is that so much of the work of kind of how to provide abortion access in criminalized contexts was developed in the global South. It was feminists in these countries who had to figure out, right? Like I talked about Brazil, I talked about Mexico. They were having to be creative and figure out what to do, and then they taught us. I mean, the fact that Vero was like, here's all of this medication for free, and we will volunteer our time to help American callers, even though we don't speak English, and we will train you on the accompaniment model. I mean, she did that because she believes in this in abortion access as a global feminist project. And I think that is such a clear lesson, because the feminists throughout Latin America, they collaborated all the time, they exchanged ideas, they exchanged resources, they helped each other with infrastructure. I mean, there was this real spirit of collaboration, and as soon as Dobbs happened, or really it was in 2021 when the Aid and Abet Law, SB 8, passed in Texas, I mean, Vera was immediately like, I'll help. She went on Univision to offer. And so, I think it's a couple things. I think it's that they had to figure out these models in a criminalized context. They never had legal abortion, so they had to figure out something else. And it's just this commitment, this sort of shared belief that everyone needs to work together in a way that I don't know I've seen as much from maybe activists elsewhere, or from the US, which isn't to say that it doesn't exist, but I just do think that spirit of generosity is really powerful. And even within Europe though, Poland is one of the only countries in Europe with a strict abortion ban. And so really among the European activists, it's the Polish women who are kind of the most bold and the most radical. So I do think, I don't know, I can't remember what the analogy is with well, whatever, I'm not even gonna try because I can't remember, something about a diamond. But I think the conflict and how hard it is really is what leads a lot of people. And there's not a system for them to have to react against. There's no system. What they're doing is filling a void. I think that can be easier sometimes than when you have a huge nationwide clinic-based system that's been entrenched for decades. Doing something new, when you have that existing, I think is harder than building something when there's kind of open territory as well. Yeah.
Hello, I might be able to give more detail on a past question. The main holdups that I've encountered from the University Health Service director have been, one, a need for, or a perceived need for a 24/7 doctor on call, which the university currently doesn't have, and two, the current level of access that Planned Parenthood has, and they don't feel that it's necessary to increase the level of access for university students because Planned Parenthood is so close. I also have a question of my own, which is a large thing that I've seen in research for getting medicated abortion on campus is making students aware of it. A lot of California universities have medicated abortion, but people will go out of state even to get medicated abortion because they don't know that their university offers it. Have you seen anything that's been very successful for getting out the word for existing abortion services?
I don't have kind of specific traction numbers on this, but I know that there are a number of organizations, like Plan C, for instance, and Mayday Health, that do these really big, bold public campaigns. Like they've bought billboards, they'll do signs on the side of trucks that, that kind of drive around. Of course, they're doing social media type stuff and internet stuff. And I do think that, there's sort of like sticker campaigns. And so I don't know how effective any of those things are, right? I don't have kind of numbers on them, but it does seem like they do help to get the word out. But I mean, the fact that I think the most recent data that I saw was something around like only 70% of Americans know about medication abortion. And I guess I'm always reluctant to quote a statistic that I can't remember like where it's from or exactly what the number is, but basically it's not knowledge of it, awareness of it is by no means ubiquitous. And so I think that's both a problem, for a university, but it's also just this bigger problem, which is that people just kind of don't know, or they're surprised to hear, or they think it's the same thing as emergency contraception or the same thing as birth control or something, which of course it's not. So yeah, I mean, I think it's like public information campaigns, it's talking about it, it's sharing stuff about it on social media, it's stickers, it's flyers, it's just any effort, I guess, to get the word out. But the thing that can make it more complicated, perhaps particularly with social media, is that a lot of the content gets censored. So all of the big tech platforms have been doing a lot of censorship of abortion-related information, even when it's, accurate public health information. And so that can be, it's not always straightforward to share information about abortion, but there are ways to do it.
Hi, thanks for being here. I would assume that medication abortions are also somewhat limited by the time in pregnancy when they're appropriate. Mm-hmm. And so that the other challenge in a college environment may be whether or not people get to the doctor early enough for a medication abortion to be actually an appropriate way to have an abortion. What is the timeline actually for like when you could do misoprostol and Miffy and Miso, whatever they are. Yeah.
So the World Health Organization actually has protocols at different phases of pregnancy, so through 12 weeks, and then it has basically like if there isn't, depending on the situation, if there isn't other options, they also have protocols for 12 to 24 and 24 and beyond, which is not to say that those are recommended, but the World Health Organization does share that information. And there are a lot of feminists, including in particular the Socorristas in Argentina, who have developed medication abortion protocols for folks later in pregnancy because they recognize what an issue it was. And so, that's not information that's widely shared. It can make some people uncomfortable. It's also a different thing to have an abortion like later at home without any kind of medical oversight. So, there is, yeah, very different. So like, again, nothing I'm advocating for and certainly not the norm, but like there are people out there who are working on that. But yeah, so the World Health Organization really kind of, its recommendation is up to 12 weeks, but then in the US, the FDA regulations are a little bit sooner than that. And so you might not be able to get the prescription after, I think like 10 in a lot of places, if I'm not mistaken. And I think that just speaks to my point of why like there's always going to be a need for clinic-based care. There's always going to be people who, for whatever reason, including they're not eligible because of the gestational term, that they're going to need to have a procedure, and they should have access to a physician and support to help them through that. So yeah, I mean, it's not a silver bullet. Medication abortion isn't kind of a solution to all of the problems. And there has been some frustration, I think, with folks in the movement who work for things like a Planned Parenthood or like a brick and mortar clinic, or they work for an abortion fund where they're really focused on helping people travel out of state. So this was a thing that the abortion fund folks in Texas talked about a lot, which is that they're like, we love abortion pills, we think they're great, we want everyone to know about them, we want everyone who wants them to have access to them. And we get so frustrated by this idea that like, oh, no one has to worry about Dobbs because we have abortion pills. And so I think it's just really important that any of those conversations about how powerful and radical and revolutionary they are is also coupled with a really careful acknowledgement that they're not a good fit for everyone.
One last question from another Maryland.
Yeah, sorry, the Maryland people are showing up today. I have two questions. One of them I think I just forgot. But for insurance coverage of medicated abortions or abortions at brick and mortar institutions, how does that work when the legality varies by state, but insurance companies are nationally covering? Like, what rules do they follow?
That's such a good question. I have no idea. I just want to be really honest about that. Yeah, I'm not sure. I mean, I know that after Dobbs, like, there were some employers that talked about, oh, if we have employees that, you know, they're national employers, and I think maybe Chase Bank or something was one of them, but like, we will pay for our employees to travel out of state. We'll make sure that their employer-sponsored health coverage is covering it. So, you know, I think that there's probably, in some cases, employers that are doing that. I also know that many blue states have created funds. They have set aside public funds to support out-of-state patients, and so they're kind of, you know, they're recognizing that patients who are traveling out of state might not be able to have any kind of coverage, or either no insurance coverage, or maybe because the travel costs are in addition to the cost of the procedure, an abortion fund might only be able to cover them so far, and so there are the state funds that are set aside for that. I think Oregon actually has done that, so like, I think that that's a really, really great thing. And this isn't related to insurance specifically, but just that cross-state communication. There's a network in Illinois, which has become such a receiving state for patients who live all over the South, and the acronym is CARLA. I can't remember exactly what it stands for, but it's something about cross-state line kind of coordination of care for people with complex pregnancies. Because, to your point about insurance, but it also extends to other things, when people have to go out of their state for care, there's all kinds of other factors that you have to consider. And medication abortion can make that complicated too, even from a legal perspective, because if someone lives in Texas, they go to Illinois for care, let's say they have a medication abortion, so they're given the medication in Illinois, but what happens if they take it in Texas? Or what happens if they take it in Illinois, or at least the beginning of the protocol, but then they actually like end the pregnancy in Texas, right? So there's all kinds of stuff with state lines, both with insurance coverage and the legality and the provision of the healthcare itself, that are just complicated, and that people are, you know, have had to, like, I think now things are more figured out, but certainly in the beginning it was a little chaotic.
Great. Thank you all for being here, and please join me in thanking Rebecca Grant.